On this match now.
Good morning, y'all. Hi.
Good morning.
Good morning,
Good
good morning.
morning. Hey, Norma.
Good morning, sunshine.
Good morning. Hey, Piper.
Good morning.
Good
Good
morning.
morning. Good morning, beautiful people. Anthony, Dell, Marco. Hi. All right, you all. We are moving and grooving. People are coming on in. We've got about 31-ish
31, yeah.
folks. Here's Miss Terry, HST. Hi, Dwight. Hey, Brandon. Good morning, Brooke. So just quick housekeeping. Angie and Kevin, both y'all are co-hosts. Do you all does one of you want to share your slide set, or do you want me to share?
Hi, Jamie. Could you go ahead and share, please?
You betcha. I'm ready to roll.
We are now 5. That's good.
All right, y'all. It is 10:05. We're recording. Good morning. Good morning. This is our second session for our Regional Linkage to Care QIP project. Let me share my screen and I'll turn it over to Oscar. Also, quick housekeeping since I'm sharing my screen. Our Dallas County peeps are all co-hosts. So if you see someone else sneak in the waiting room or need to mute or unmute, you all can kind of help me with that because I may not be able to see it. But Oscar, kick us off. Take it away.
Well, I would like to give the pass to Miranda. I mean, ladies first. Please, Miranda. Good morning. Yes. Is she in? You're saying something, you're muted.
Miranda right now is with an intern that just came in for our outreach side.
All right. Well, welcome everyone. See 31-ish. Those who are joining together, please put the name on the chat just for attendance purposes to see how many people are we bringing in the table and the CQM culture. Thank you very much to EHE to joining this effort. Thank you precisely to you. You are the stars. Super recipients are the start of this game. And this turned to be a very good practice for the quality improvement project. So welcome again. Good to stay. Next passage to Angie.
All right, friends. Hi, everybody. This is Kevin. Thank y'all so much for being here. So we are just going to do some kind of what Oscar just said. If you could enter your name and organization into the chat so we can know who you are. And for attendance purposes, we'd really appreciate that. And just so you know, make sure to use the chat room to interact with your colleagues in our team. We highly encourage webcams if possible, but we totally understand if you can't. And also, this meeting is being recorded and will be available for sharing along with the toolkit for this meeting right after this meeting. So we're going to go ahead and get started today. And thank you all so much.
Good morning. We're going to go over some of our objectives today. So we're hoping that, we are today going to discuss 3 case studies in our area. I think you'll be really excited about that. Thanks to those who volunteered. Also observe some problem-solving skills and actions that staff took during these case studies that may be helpful in your agency and helping you to develop some of those same skills or figure out some ways around some barriers that you may have now. Worked with our peers to promote a medical neighborhood and care coordination. We know a lot of this is happening already, but we change terms of things from time to time, but I think there will probably some new people on the call, and it's an opportunity to also to reach out and develop relationships with other participants who are on the call. Lastly, we want to talk about our expectations and next steps for the rest of the year for our Linkage to Care project. Next slide, please. And so for our toolkit, it's always available in glass cubes, and we'll have the presentation slides from today. There may be some edits to the slides that we have because I don't know if we got everything for the case studies. So just stay tuned for that. We usually let you know when everything is available and posting glass cubes. If you don't have access to glass cubes, please shoot one of us an email so that we can make sure that you get that. And I'll hand it back to Kevin.
Perfect. And as Angie said, if you have any issues getting into glass cubes, I'm gonna go ahead and put my email in the chat. Feel free to reach out to us if you need any help, and we'll send you an invite to give you access to it. So today, for our icebreaker, we're going to be doing a story circle. Next slide. So the objective of the story circle is to share any personal or professional experiences related to HIV and quality improvement. So what's going to happen is we're going to break you up into small groups around 5 people each. These breakouts will last 7 minutes, and each person in the group shares a brief story related to their work with HIV or quality improvement project. Participants can reflect on a specific success, challenge, or learning moment within the group. And after the breakout, participants will be brought back to the main room. Facilitator will ask for the volunteer to share 2 to 3 highlights. And here, an example below is, this QI project is my first ever, and I was confused at first, but now I understand what we want to accomplish. Also, I feel like in our work, we do have a lot of really special moments. So please feel free to take the time to share something positive within the group, and guide each other, because this is a guided breakout room. So and here we go.
Thank you, Kevin. So real quickly, fam, I'm gonna do these breakouts. We will post those instructions back in the breakout. As Kevin mentioned, they are self-guided. So I'm gonna get ready to launch some randomized breakout groups. And so you'll automatically be assigned. Just go to that breakout group, and then I'll broadcast those instructions, and we're looking forward to that story circle. So here we go. I'm gonna open those rooms. Fabulous. See you soon. Hey, Miranda, how are you? Hi, good morning. Welcome back. Welcome back. We're learning. Maybe those stories were too good. We needed more time.
There you go. We'll go with that.
That's the first time doing Story Circle. That was Kevin's idea. So we're kind of excited to try something new. All right. Welcome back. I see Jasmine, Kim. All right. All right. Okay. Welcome back. Thank you so much. Joni said, oh, we needed a little bit more time. So just quickly, does anyone want to volunteer to share one of the reflections or pieces from their breakout? And we'll kind of continue moving into case.
Hello.
Hey, we hear you. Awesome. Well, hey, so we have Jasmine in the chat saying that she loves Story Circle. That was our first time doing this as a breakout. Jasmine, do you want to share why?
Oh, hi.
Hi.
Yeah, so I was in a room with Piper and Joni, and I'm missing somebody. Oh, I think Terry. And there was a story that really resonated. I think it was Joni's. She was one of the last to go. And it was mainly about there's some clients that we see a lot, and we kind of assume because they're using our services that they're in care. And Joni shared a story of a client that she sees on a daily basis. And through Linkage to Care, she had a conversation with the client and she found out that he was out of care for, I think, about a year. And doing the Linkage to Care project really brings back even though it's a short conversation, even though it's something that's as simple as asking, like, have you been to your doctors in the last 30 days? Where do you go for your primary care? Finding those outliers of those clients that have stop going to their doctor for XYZ reason and putting them back into care is really helpful, and it's inspiring. I've come across those clients myself.
Absolutely. Thank you. And love that. That's like totally what we're going for. So kudos, Kevin. It looks like folks really valued that opportunity to reflect on the people, you know, behind the data, behind the processes, behind all the stuffs, you know, in our dailies. So we want to continue with that, really digging into our community, and I'll hand it over to Michael.
If I can unmute. Good morning, everybody. Hi, happy Tuesday. You know, as you know, the most important thing in life is people. And we make together such a great team here. And we've listened to you over the years through these webinars and also through our ECCs that you really want to hear a lot more from each other. So here we go. We're going to go ahead and hear from HSNT that's going to share a case study with us about their work in the Linkage to Care project. So go ahead, Terry, take it away.
It might be Kim.
Oh, Kim, go ahead, Kim, take it away. Sorry, my bad.
I believe it is Sylvester on here.
Sylvester's here.
Yes, I am Kim.
Okay. I'll jump in if you need me.
Way to go, HSNT.
Come through, team. And sorry for the scare, Terry. I saw your face. You were like, what?
So would you like for me to go ahead and start, Kim? Okay.
Yes.
We're at HSNT. We have anonymous HIV testing every Friday from 8 o'clock to noon at both of our locations, the Plano Medical Center in Plano and the Denton Medical Center in Denton on Mesa Drive. And so our case study is centered around a 27-year-old female who screened positive for HIV at our free HIV testing at the Plano Medical Center on May 31st. The patient had her confirmatory labs drawn and completed the process for the referral for healthcare the same day. Just want to emphasize the fact that when our clients come in for the anonymous HIV testing, when they test positive, we get the whole multidisciplinary team involved to get them linked with services. And that is done within 7 days. So I mentioned this patient was tested positive at the Plano Medical Center. And on that particular day, May 31st, the ID provider at the Plano Medical Center was out. So the patient got linked with our ID provider in Denton. Just want to emphasize that we have a very collaborative approach. When an ID provider is out at one location, we make every effort to engage the patient or link the patient with another ID provider at another site. So this particular patient was seen by the Den ID provider on June 6th. And during,
you might need to mute, friend.
can you hear me okay?
Yeah, you go ahead.
Okay. During the initial visit, we learned that the patient was diagnosed HIV in Oklahoma, but the clinic in Oklahoma did not have an appointment available when she was tested. Therefore, the patient sought treatment at HSNT, which is closer to her residence. Again, I think we want to emphasize here that what we found out was that when the patient showed for our anonymous HIV testing, she was already aware that she was HIV positive. And I wanted we as a group to talk about that. If other organizations and agencies are experiencing the same, because we have had this to occur at both of our locations, at the Plano Medical Center and the Den Medical Center, where clients are showing up for the anonymous HIV screening, and they're already aware of their HIV diagnosis. And of course, here at HSNT, we're very excited. We're excited that they are showing up, despite the fact that the anonymous HIV screening is for persons who are not aware of their diagnosis. But by any means that we can get a person with HIV into care, we will take it any way that we can get it. So we're excited about that. So when the patient came to us, the patient had some pre-existing comorbidities. She had a diagnosis of pneumonia, asthma, and hypertension, but she had no co-occurring bacteria STI. The patient has since met with the Plano Medical Case Management Team, and the patient will have her follow up by televisit again with the Den ID provider on June 27th. And so my question for the group is, has any other organization had patients or clients to show up for the HIV screening when they were already aware of their HIV diagnosis?
And I see that Dell has his hand up. Go ahead, Dell.
Yeah, I just have a little bit of information for Sylvester, or maybe for the group, but our prevention services manager has told me, because I had to apply somebody who diagnosed in some other state was getting diagnosis out at our prevention services program. And so it turns out when people, maybe they live in Texas, but they get diagnosed in some other state, or they're diagnosed in some other state, and then move to Texas for state tracking purposes, through the prevention services, Texas Department of State Health Service, all that, they need to get an HIV test in Texas, and of course, get linked to care. But by getting an HIV test in Texas, it brings them into all of the state HIV tracking. And I guess I'm sure other people have more information about that.
No, that's I saw Joni's comment. That's a common reason. That's another common reason too, Del. Absolutely. Sometimes people are testing when they're on vacation and come back. Miranda had her hand up, and then Joni.
Hi, good morning, everyone. I was just going to say two things as we, put everything against data as well. But I know we have a medical mobile unit here at the county, and we've had some conversations, and they said, upwards of 50% of folks that are diagnosed actually have been previously diagnosed. And so I know Anthony also requested a large data set from the state, looking at all of the funded HIV testing so that we can start to get a bigger picture of, on average, we think that it's a new diagnosis, but what can we expect in terms of averages? So it is pretty common. Thank you.
Oh, thank you so much. Joni, you're up, and then Angie. Joni, you're muted, love.
Oh, sorry. Just
All
a
right.
comment, as Dell had mentioned, people, getting tested to get into the system of care. I think that's part of the problem, is that people don't feel like they can get into care without being tested. And some people don't want to be tested again and go through that. So I just wish there was more education that once diagnosed, that initial diagnosis can be used, kind of in perpetuity to get you into services. And so I do know that a lot of people feel that way, but I sort of hate that that they feel they have to. Now, if somebody wants confirmation, we get a lot of people tested out of the country. And so they come here and they don't acknowledge that they've previously been tested. Maybe they don't believe it. They're in denial. It's a cultural thing. So that I can certainly see. But I just wish that people didn't feel like they had to be tested a second time just to access services, even if they're coming in from another state. Sometimes that can be traumatizing for people. And so just wish that there was more education and people realize that they could much more easily get into services now than maybe in years past. That's all.
Oh, word. Joni, I can always rely on you to kind of like hit that right where it is, even the stuff with Texas, like to Dell's point, we do, Texas is prickly about having its confirmation, but you should never delay care for that. You can have the rapid, and, there are so many ways around that. So, I think that there is a great amount of education needed for the community. And then there's a great amount of education needed for the providers too. And that's a problem that happens all across Texas, where people delay that entry because of the bumper cars and misunderstandings. Angie, and then we'll move on to our next case study.
Yeah, thank you. I just wanted to just kind of add on to what everyone else is saying. And just to remember too, it's not a loss, it's still a win. I think Kim is saying the same thing. It's just the opportunity to get them into care. A lot of times too, especially with the QIP that we're doing now, we won't know, you won't know, that patient is always, sometimes you won't know if they already have a positive test somewhere else. So there's a whole process that happens, when they're positive through surveillance. It goes up to the state checks all the other places in Texas, goes up to, federal level. They check all the other places to see if this person is positive somewhere else. And so, but when I was in surveillance, and I guess it's still done the same way, I'm not sure. It's like where you lived when you first tested positive gets that positive count, morbidity, that new case, so to speak. So it's still important whenever they come in, because sometimes people test because they're not ready. They don't believe the test they got. They thought something was going on. I was in a mobile unit. I was at a, homeless shelter. We do all kind of outreach testing, or even at, a doctor's office or in a hospital. Sometimes people just aren't ready for the diagnosis. And so they have to test again. And when they're ready at that time, then they move forward, they come in, they learn about our system of care, our medical neighborhood, they learn about all the different places that they can go. Because we have some storytelling at our place and our thing, and things are a lot different now, and things are a lot better. So I think it's really helpful however they get in, whenever they get in, that they are ready for treatment and that they learn about all the services that are available to them.
Yeah. Thank you so much, Angie. Now, I know that Belen is next, but I was told that Ms. Piper had her hand up and I skipped her, and I am very apologetic. And I just want to give her the chance to jump in here real fast, Ms. Piper.
I had my hand up. I apologize. I mean, I can always say something, but let's let the conversation move forward. I'm sure I'll have another something to say. I'll lower my hand.
All right. Maybe it was just a whoop kind of thing. But thank you so much. And Belen and EHE team, take it away.
Yes. Can y'all hear me? Yes, okay. Actually, this case will be presented by Marco, one of our care navigators. This is his case. Marco, you can take the floor.
Hi, everybody. So I had a very interesting case. About like we'll say over a month ago at this point, we had like a 17-year-old trans Latina woman here in the clinic that was diagnosed with HIV. She was coming in because she was like feeling symptomatic. I don't even think she was really anticipating for them to really run an HIV test. She was definitely shocked when the results came in. Oh, sorry, is the mic not? Let me fix this. Can you hear me better now?
Oh, that's better. Yeah.
Okay,
Your microphone must
okay.
have been down here, but now it's here. Yeah.
Ooh, how do I fix this? I can't fix it, so I'll just hold it. But anyway, so I was attempting to link this child with the Children's Arm Clinic. This client is technically not eligible for Ryan White because she's a minor. She has to therefore apply for basically like the Medicaid access program. And this made this process a lot more complicated. So this child is not really willing to disclose her HIV status to her parents. Makes it more difficult because we're going to need her parents' involvement in the application process to Medicaid. So for this application process, they're requiring both of her parents' income because both parents are working. They're requesting at least one parent be present to sign legal documents. Additionally, because she has a sibling, Children's Hospital is also wanting to link her siblings over to Medicaid as well. So they're also requesting birth certificates not only for her, but also for her brother or sister as well. We have been trying to get the child to go in to register for Medicaid. Like Children has a really awesome program. And basically their program is set to where even if like someone is applying and the application has not yet been approved, if everything's pending, Children's is willing to like suspend the billing process and not bill them until after Medicaid has kicked in, which I think is incredible. The only issue right now is this child is not able to convince her parents to come in. So we have been brainstorming with a social worker ways that she can either disclose her status or ways that she feels that she can actually convince her parents to enroll her for Medicaid. I think right now the issue is her parents are kind of like, why do you really want to enroll for Medicaid? Obviously, there has to be like something else happening. And so she's not really willing to press any further to get them in. We've been trying to convince her to say like, oh, we'll tell them like you need like your flu shot or like you need like vaccines or that just any child needs to have access to medical services in case of an emergency. But for whatever reason, we're not able to convince them. She is just telling them that she's just interested in it. So we have an appointment set up for her this week to go enroll with the financial office. She's going to go with her mom. Apparently, she does already have the parents' income. She just needs her mom to actually go and sign the legal documents. That's just been a challenge in and of itself. So luckily, Children's Hospital said as soon as she gets those documents and applications in, then they could theoretically leave with medications the same day. The child saying that when she applies with her mother, she's not willing to pick up the medication, obviously, because her mom's going to be like, hey, like, what's this pill bottle for? But so as soon as she is able to apply, I'm going to go ahead and take her back to Children's Hospital so we can pick up the medication. But I think this is just one of those really, really sticky situations that I think it's unfortunate that, you know, we don't have like a kind of like a program for this specific case. I also just want to mention quickly, she is trans and she says she has like a safe place at home, but she doesn't really feel like accepted or she doesn't really feel accepted from what I've been able to interpret about her living situation. So it's really unfortunate.
Wow, thank you so much for that case study. It is so important, you know, and you're featuring things that are really important. You know, based on what Dr. Furness from the CDC shared with us in April, baby, we can expect an increase of these cases. We can expect an increase in these cases. So what are we going to do with these types of things? So I see some questions coming in. Norma's asking about, can she declare herself legally as an adult? Has anyone had experience working on things? Oh, go ahead, Marco.
Oh, well, I was gonna say I had actually mentioned this idea because my supervisor had talked to it to me. I don't think that's something that she's interested in. She's definitely still living at home, so I don't even know if she's even eligible to apply for like emancipation.
What are some other solutions that folks may have who've worked with kids or have worked with, parents? Dell's always the first to raise his hand. Go ahead, sir.
I don't think it's a good fit for this young woman, but there is a process called becoming an emancipated minor. It's a court process. Basically, it's a fit for youth who are self-supporting, not living in their home generally, yeah, but they're actually supporting themselves and taking care of themselves. So there's a process that might fit some other young people, but since she wants to live in her home, stay there, probably isn't self-supporting, or at least I didn't hear that part. But I wonder if there's not some more youth services that might be in, not necessarily in the Ryan Whitefield, but Brian's House has recently announced that they're back with a presence in Dallas. So you might check out Brian's House and see if they have any services for this young woman. But with her living at home, it's just always going to be complicated about concealing medications, these kind of things. But I just wanted to share the bit of information about emancipated minor.
Ooh, we are going to save this chat room too, because on top of the goal that's being shared, live, the chat room be blowing up. So I'm not sure if anyone wants to pull out anything in particular. I see that Nisa, someone had asked, like, can legal hospice, like, how about this? They've experienced, and it looks like not Nisa, Jasmine had responded, or Nisa had responded that there is a group. So I don't know, Nisa, if you want to share a little bit about your experience working with that group. I don't know if either Jasmine or Nisa want to talk about what experience legal hospice has with these types of cases, or how the process works. How you doing? It's great to see your face, friend.
Hey, how are you? Good to see you. Yeah, so I actually have my younger sister who needed assistance with a particular issue when she was about 16, 17. And I was already a client of Tennyson Women's Healthcare, but I was an adult. And I referred her there because I've been told that they will assist any age group. So I'm not positive like what the requirements are or what forms have to be signed, but I can reach out to them and ask. And I know since I visited that clinic, it's been like 8 years. They have opened more clinics in like Southeast Dallas, off of like East Dallas 30 area, because I initially would go to a location located in Garland. And as far as the emancipated minor, I have never worked with that here at Legal Hospice, but I'm familiar with it and I can ask our attorneys. I'm not sure that it's something that we would be able to do, but it's definitely a question we could ask, since we do serve minors sometimes as well.
Thank you so much for that. Love, love, love. Okay, I see Joni actually has a really interesting point as well about working with the consulate. Joni, do tell. That is something I've never heard of before, and I'm fascinated.
Well, so as many of you know, and maybe some of you don't, AIN used to have a Manos Unitas program. We worked directly as a pilot program through the Mexican consulate. Miranda worked here at the time and was very familiar as well. But they offer a lot of supports, and actually 4 of our previous staff members still work at the consulate as far as I know, and provide services. So just thought they might be able to provide something that would be more comfortable for the parents, that might be more culturally specific to help support that, even the Medicaid application, or even support disclosure down the road when she's comfortable. But just felt like sometimes there can be some uncomfortableness just dealing with our systems and kind of lack of knowledge of how everything works. So not knowing the family specifics, just thought that that might be a potential resource for them. And they do have a lot to offer at the Mexican consulate. So just a thought.
Fabulous. Now, I see something that came from Brandon as well, talking about a mentee. And so I don't know if, I just want to call in one more time. Does anyone have any cases where they routinely test people who are younger than 18, or, have kind of like a sense that they might be moving that way and have some nerves about it? They'd like to just get out real fast. Sangeeta.
Well, I can't speak to if I've had that firsthand experience with a younger than 18-year-old, but what I can say is from the surveillance perspective, there's a lot of data that we don't submit purposefully for the purposes of Ryan White reporting that we have to exclude, in which that fits the 17 and under category, or they're just on the cusp of like turning 18 or something like that. So I think that the age factor is a large barrier because it goes to show like within the healthcare system and how we navigate it, like there's just a matter of like you need one more year on you or a couple of months more on you to get proper care. And I think that also is something that like policy and legislatively speaking, Ryan White could potentially consider in future programming as a way to, you know, go about further serving this medical neighborhood idea that y'all are kind of talking about and improve.
Ooh, amen, sister friend. I would definitely share this slide set with our federal partners and with our state partners. I would also share this slide set, particularly this case with Benton, you know, just because he does a lot in the state house talking about these things. And this is such an important case that kind of shows that like, you may have created these policies with the best of intentions. However, you are creating misery and potentially death. So, all right, let's move on to our next case. So last but not least, our friend, the powerhouse Dwight Harry from ASD is going to share a case more from the Ryan White side. We've heard from, you know, kind of the EHE side. We've heard from a blended EHE Ryan White side. And now take it away, Dwight.
Top of the morning, team. It's my pleasure to introduce you to our medical case management staff, Christy Halliburton and LaQuasia Turner. They've been involved with our QIP project from the fish diagram to the aim statement to the referrals and validations. So they have an outstanding case they'd like to present. Christy, go ahead, and LaQuasia. Thank you.
Good morning. Our case study is about a 30-year-old bisexual Black male who has been living with HIV for 4 years. He came to us experiencing hopelessness, feelings of worthlessness, despair, the stigma. He had, in his since being diagnosed, turned to drugs and alcohol as a way to try and cope with his diagnosis and the overwhelming emotions he felt. In May of 2023, he became a resident and a client of ASD. At the time, his viral load was 86,400, CD4 count of 41. He had established care in the past immediately upon being diagnosed, but he had fallen out of care. We have crisis intervention specialists, and they basically work with our clients with any kind of mental health, emotional traumas, feelings, trying to help them adjust as residents and clients of ASD adjust to their diagnoses. He was able to establish a rapport with this client, and the medical team was able to get him reestablished back with Parkland with his original doctor in his HIV care. Then after the team got that set up, we connected the client to both inpatient substance use and outpatient supports. We also offer pillbox assistance. He felt a little overwhelmed with taking it. He didn't like taking medication. So the medical team offered to give him reminders and to set along with him to help him fill a pillbox weekly and get him in the habit of taking his medication as prescribed. As of February of 2024, his viral load was 44. That is a huge accomplishment. His CD4 count is a strong 389. Just a few weeks ago, we found out the resident got a housing voucher. He's now touring independent living apartments with his non-medical case manager. He's going to graduate from our program. He wants to go back to junior college. He's still engaged in mental health care and talk therapy. He's still engaged in NA to maintain his sobriety. And I think this case in particular shows us that in addition to, of course, HIV care, we need to treat the whole person. I think it's important to look at everything going on in their lives, medically and mentally and emotionally, spiritually, and try and address their needs as a person. And treat them with compassion and culturally sensitive care. Listen to what they want to achieve. And by doing all of that, like this success story, I think we can set people up to be a success in their future.
Love, 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 love that. Absolutely. You know, say it with me. Housing is medicine. Food is medicine, right? And so it's really important to note that while we're focused on the clinical care and clinical outcomes, baby, you have to do so much in order to get to there, right? It's not just you snap your fingers and people fall, you know, into line. Like there's this thing called personal agency, and people struggle a great deal. And as a human being, like I'm a human being, I know that I have struggled. So I get it. I don't know if anyone has any comments, reactions, concerns, ahas based on ASD's case study.
You know,
I have a question. I wanted to know a timeline for how long the process was from entering into services to getting ready to graduate out.
So he entered into our services in 2022. Yeah, and we got him engaged in his medical care very quickly. You know, addressing his medical compliance and his medication compliance was actually the easiest part of the whole thing. Then, of course, we moved on to substance abuse and his mental health and emotional health. He became undetectable in just under 6 months. And then from there, it's been a work in progress with the whole person. And so as of just a few weeks ago, really, is when he made the decision he was ready to be independent, that he thought he could succeed without all the case management help, without, you know, a staff, a team of people around him. And so we're supporting him and helping him launch. He feels he's ready.
Thank you.
So good. Jamie, go right ahead.
Yeah, I think just to wrap up, I also really value this example, again, to speak to the whole person. It speaks to social determinants of health. It speaks to, you know, ASD, like this is focused, you know, this was a use of maybe Ryan White housing dollars, but oh my Lord, look at all the different things that are involved and wrapped around with the case management team, the crisis intervention team, and so much more. And so I really appreciate how this is representative of that internal team effort, as well as working with external organizations, whether they be the inpatient or outpatient, working with them to navigate getting a voucher and also navigate, you know, more permanent housing. So that's really tremendous. And I also want to say what I love about these case studies, we have such a diverse group here, right? Some of us are clinical, some of us are non-clinical, some of us are EHE funded, Ryan White, or both. What we really want to do is say everybody has skin in the game in this regional QIP, right? We're all connected to it. And so I really appreciate all three of you for sharing. I want to give kudos. I do want to celebrate Marco as the newest EHE CHW, also for bringing such an incredible case. I think we have a lot of utility here. So fabulous job. And we're definitely saving the chat. I think we're going to move on to the next segment of our QIP webinar today, which is going to, well, Dee, let me throw it back to Dee to give you some thought prompts and then we'll move forward.
Yeah, for sure. We finished up, wrapped up um our first section here with the case studies. So we just wanted to leave you with some prompts. Just consider what you've learned from your colleagues in application to your QIP. I see that you guys did love this section a lot. A lot of feedback was able to be shared. So what examples might you want to bring forward for future case studies? And then just thinking about what your system level and agency level changes would be that can help our 2024 Linkage to Care QIP reach our goals.
Love it, Dee. Thank you. And there's utility in these spaces. And again, a lot of utility after. And a lot of times stories are the most impactful. So we definitely want to continue to bring these forward. As we think about moving into, so what do we do now, right? As we're continuing to work through our hopes and our fears in tackling our regional QI project. What we want to do is continue with having a really engagement-based webinar today. We're going to have 15 minutes in breakout groups. We have 2 breakout groups. They're going to be randomized. You've got a facilitator with Octavio and Dee, and then you've also got someone to help monitor the chat in each room. But essentially, we want to have this as an open discussion where we want to say, what are your hopes when it comes to implementing your QI project? Maybe it has to do with these medical neighborhood concepts or providing holistic care. Maybe it has to do with like, I've never done a QI project and I don't really know like the methodology, right? There's no wrong answer, but we want to capture folks' hopes and fears. One, to sort of allow us to memorialize where we are in our current state. We know folks submitted and we are thankful for all of the submissions we got between Friday and yesterday for this regional QIP. So the hopes and fears help us collectively understand one another, again, create peer learning and troubleshooting as a group, and also helps Dallas County prepare value add support, whether it's TA or these webinars. So you'll be randomly assigned. D. Octavio, if you guys get hooked up in the same place, I'll move you, so don't worry about that. But you'll have 15 minutes, and then after that, you'll be transported back into the main Zoom room. Any questions about the hopes and fears breakout, or a thumbs up? Sounds good. Okie dokie. Let me launch some breakout rooms. Recreate. There's going to be 2. I'm going to recreate. I am now opening them, and we'll see you here in just a few minutes. AJ, I'm moving you to 2 with OP. All right, y'all, you should be able to see your rooms. And I'm sorry for your audio troubles. I don't know if calling in helped with that. Hey y'all, welcome back. Thank you, Norma, for some great info in the chat too, right before the breakout. Okay, fam, let's talk some hopes and fears. So I know, oh, I'm off camera, sorry. Oh wow. Octavio, why don't you give us just like some lightning round feedback and then kick it over to Dee and we'll keep moving and grooving.
Of course, though it was a great conversation, and I think that's been the theme
since the beginning of the webinar, right? The conversations and how we are all engaging together. We had a couple of fears, which was a great thing, but a lot of hopes. People want to continue having the buy-in that they've had for the previous year, so that was very positive. Also, the neighborhood component, how that has been influential with the services being provided. Also, there was a lot of vulnerability in terms of how we need one another and how we'll have an impact on what we're doing collectively. And Sonia and AJ reinforced their commitment to being of support to the subrecipients to make sure that beyond the QIP, they're able to continue providing the services to the community. And I think that's it. I don't know, AJ or Michael, if I may have missed something, but that is in essence some of the highlights from our breakout room.
I second that, OP.
Hey, and I know for our group, I'll just go ahead and jump in and share a couple hopes and fears from our group. One thing we mentioned was efficiency and effectiveness and validity just throughout the year. Just being able to, one, keep up with the numbers. Someone mentioned just having 100% or close to 100%, because I know that's where we're aiming for. And they wanted to just make sure that that's still there, going throughout all of the quarters, developing a standardized process, whether that's with your agency or just overall. Also increased outreach, community engagement, and empowerment. And one thing that someone mentioned was the capacity. So that could be a hope, and it could also be a fear, just the capacity not to do things. And then just going into more fears, maintaining linkage to care. And one thing that was mentioned with the linkage to care was those life barriers that you kind of just can't escape. Another fear was not having all the deliverables for each quarterly submission, and then just the data quality. Throughout our group, we had a great discussion around these topics.
Thank you, Dee. Yeah, similar hopes and fears. So hopefully that can unite us, right? And we can reach to each other when we're feeling a little overwhelmed at times, or some of those fears are kind of speaking a little bit louder, but still sort of root ourselves in our collective hope and common purpose and forward vision. So thank you, Dallas County. We're going to take a greater look at those again and think about how can we utilize the hopes and fears to deliver to you the best support for this regional QIP. Dr. Salinas, I see you're unmuted. Did you want to add something real quick?
Yes, real quick. One detail that was mentioned in the group that I think is valid is maintenance. How to maintain that retention. I mean, the retention in care is the key to go into the viral suppression, but there is always a gap in that retention. That one of the fear of the group was, how can we maintain that viral suppression? How can we maintain that methodology going into function? And one of the fears, very intense, was, what if we cannot improve the care?
Right.
So
yeah, thank you. Thank you.
Oh, thanks, Dr. Salinas. Hey, really quick, I know we're coming up on time. I kind of wanted to touch on some expectations before August. So, friendly reminder, we're working in the DNS phase of the PDSA. We will be offering, again, shout out to those who took our offers on the coaching and actually taking that TA on the PDSA. We know it's new, and you guys are working it like champs. So August 15th is that next submission due date for both Ryan White as well as EAG. So keep that in mind. And Glass Cubes is our friend. Okay, we're going to utilize that. You guys have been doing a great job at it so far. I'm going to jump over to the next one. And then right now, this is what our timeline is looking at. So we are in the second part of our 4-part QIP series. So between now and August, sites we're in their action period, and the phase of doing the work is moving through the PDSA cycle to accomplish their aim. So that's where we are. And we will have a QIP session in August and one in October before our annual fun QIP poster symposium. So looking forward to seeing all of you guys. That'll be a blast again.
Thanks, EJ. Dee, round us out, friend.
Yes. So just looking forward to our next submission. September 15th, 2024 would be our next submission for our PDSA worksheet, as well as the QIP metric for Ryan White only. And then after that, we have our December 15th submission with the same things. Coming up later this year, we have our QIP poster symposium for World AIDS Day for 2024. Woo! The submission due date 2 weeks prior to November 18th, 2024. And this applies to both EHE and Ryan White subrecipients, regardless of funding.
Yeah, and I just realized we did on AJ's slide, I put the next submission was August 15th. Whoopsie, edit, I'll touch that up. The next quarterly submission is due in September. So my bad, y'all. August we'll have our consultant visit in Dallas. So our QIP session, instead of it being virtual, we'll have it in person. We can maybe do a hybrid option, you know, as a backup, but just keep that in mind. And then Kevin, you have your hand raised. Maybe I'm confusing myself, but talk to me.
No. Hi, friends. I just wanted to share that also in alignment with the QIP poster symposium, we have solidified a day for that. It's going to be December 6th. So just keep that in mind. And also the World AIDS Day Planning Committee will be meeting in a few weeks. So I'll make sure that information gets sent out to you so you can be part of the QIP poster symposium planning process. If you aren't already, I see a lot of people on the call that are, so thank y'all for taking the time to join yet another meeting, but I hope that you all are finding it impactful so far. I did also want to send out a reminder to those who have not submitted their submissions for June. We are still missing a few submissions from a few subrecipients from the Ryan White side, so I will be sending out an email to remind you all to submit those by the end of the week. Just so that we are able to do our internal analyses and reach out to you to schedule our one-on-ones. So be on the lookout for that. No sweat. We just want to make sure we get all the things that we need internally so that we can meet with you all to decide some next steps. But just wanted to let you all know that. And once again, thank y'all for joining today. Love you all.
Thank you, Kevin. Yeah, so let's kind of just do a quick recap. Again, today's been a really meaningful day, getting to look at, you know, sharing our individual story circle, moving to case studies, as well as getting the opportunity to share our hopes and fears with one another. So thank you for that communication and honesty. As AJ laid out, what we hope and sort of some expectations between now and the August webinar, or even the September submission, is how are you going to take steps to accomplish your aim? What test of change, what QI idea are you and your team generating? And how do you get the opportunity to do it, to practice it, and then sort of study, see what happens, what works, what doesn't, you know, what's kind of neutral. So we really encourage you to follow your PDSA Plan, Do, Study, Act cycle, utilizing that model for improvement. As always, you're never alone, right? We are one, we're stronger together. So holler at us for assistance. We know Kevin is a Ryan White contact. AJ and myself are for EHE fam. So we have our upcoming key dates. We have the new sessions. Again, we mentioned August will be in person. Kevin let you know that the World AIDS Day Poster Symposium is December 6th. And again, the next submission is the 15th. So keep this there. Both programs, Ryan White and EHE, do have a reporting schedule. It's a one-pager Word doc in glass cubes for EHE. And then it's part of your performance measurement workbook tab for Ryan White. So we do want to just make sure you all have as much advance notice as possible. I'm gonna launch a poll here very quickly to close us out for the day. But beforehand, I want to give Miranda and Oscar an opportunity to share any closing words. And Sonia as well. Hey, Sonia, we see you.
Yeah, I would like to pass the ball to Sonia Miranda first, please. Go ahead.
You know, Commissioner's Court is going on today, so I'm trying to engage in 2 meetings. But again, in our breakout session, I really did want to focus on the hope aspect of it and know that, you know, we're here to support you in any way we can. And again, we're always looking to see if there are policies or procedures in place that are preventing us from, you know, creating a system of care that we know would be better for our clients, how we can create workarounds, and then in working with, you know, our state health department partners, look for ways to collectively, right, disagree with what some of the provisions that they're rolling out. But definitely appreciate all of you and the work that you're doing to create a patient centered network for our clients in the Dallas area.
Go ahead, Oscar. You can round us out.
Okay. Well, again, thanks so much for each of you to give us this time and be part of it, be part of the team, be part of the effort. Not bring the situation is not the end. Bring the situation, let's build a solution together. I mean, the case study is fantastic. It's always been a good practice, and I hope you like it. I hope you enthusiastic enough to bring more cases to discuss and find channels that work for everybody. And again, thank you very much for approach the client, not just a system, but think about the human being is a biopsychosocial triangle. Thanks again.
Amen.
Yeah, case studies were fantastic. It's always nice to have that human side of somebody's experience and how we can support people. So I do love that aspect and look forward to seeing more of them.
Yeah, thank you, Sonia. Oh, go ahead, Oscar.
Well, the more we have those tablets, we can improve the technology, apply the technology into that to improve the quality of care. Reach out.
Yeah, I know, right? To keep having a conversation with Oscar amongst all you all, because we have a few more minutes. I do definitely want to echo that as well. I know that there can be fear associated with utilizing the tablets because of the liability, but just know that all of that is, you know, built in the structure of the agreement, and so that should quell that fear that if you're not responsible, if a client, you know, loses it, sells it, you know, whatever happens to it, it's like I said, initially built in. There's the replacement cost built in with that, so we definitely want to utilize them and take a chance. So thank you for that too, Oscar.
Word. Thank you, Sonia, for advocating for us at Commissioners Court. We really appreciate you. You know, I don't miss doing that myself, and so I value every moment that you're doing it. So yeah, keep in mind, we can share more about continued and other sort of pieces that we can leverage, right? We can cross some technological bridges as well as some privacy and confidentiality bridges and other pieces like that. So let me launch this evaluation poll. We have about 21 people. Some of those are going to be co-hosts, so I'm hoping to get at least 75% response rate. But y'all should see, we'd sort of like to know if the meeting and discussion met your expectations. We have strongly agree all the way through strongly disagree. We're also wanting that little Goldilocks moment. Was the meeting just right, too short, too long? Or you're like, you know, I mean, I don't really have an opinion. We want to know if you feel there were enough opportunities to participate. Definitely lesson learned to give some more time to the story circle. So taking that as a note. And then we want to make sure the content today with the case studies, hopes and fears, as well as clearly outlining expectations, that was just enough, too much, too little. And then the last question is we want to make sure there's always clarity on what happens next. So if you can take a moment to complete those, just let me know. And with that, you know, once we have your poll responses, we wish you a wonderful and fantastic day. Stay tuned. The recording will be posted to the YouTube CQM page, and then you'll get instructions on the pathway for your respective materials and glass cubes. Give yourselves a round of applause. Thank you for our case studies, and have a fabulous afternoon.
Thank you, Jamie. Bye, friends.
Bye.
Thanks, everybody.
Awesome.